Welcome everyone to Medscape. We're so excited to cover a topic that's very near and dear to my heart, talking about loneliness today and health and brain health specifically. I am Dr. Indu Subramanian. I am a neurologist at UCLA. Very excited to interview Professor Holt-Lunstad today. Julianne Holt-Lunstad is a professor of psychology and neuroscience and the director of the Social Connection and Health Lab at Brigham Young University. But she's also the founding scientific chair and board member for the U.S. Foundation for Social Connection and the Global Initiative on Loneliness and Connection. She's worked very closely with Dr. Vivek Murthy, who is our Surgeon General, on the important topic of loneliness and how it affects all of our health. Perhaps we could just hear a little bit about your background for a minute.
I really started out in my doctoral training looking at laboratory-based studies and how stress impacts various biological and physiological kinds of markers, really trying to understand how it is that stress impacts health. But of course, part of that was always social factors. So the extent to which social support could buffer the effects of stress, and how relationships can also be sources of stress. Well, so then I get into my career, and I'm doing a lot of laboratory-based studies, really taking this farther, but starting to recognize that while I'm trying to elucidate some of these, biological pathways, that really outside of a small group of academics, that more broadly, it's not widely recognized that social connection or lack thereof is important for health. And this idea that maybe it's associated with emotional well-being, but perhaps not relevant to physical health. And so that really led me to do my seminal meta-analysis on looking at I first looked at all indicators of social connection and how this impacts risk for mortality, and then followed that up with one looking at isolation, loneliness, and living alone as markers of lacking connection and how that leads to increased risk for earlier death. And so I think it was through those, really looking at this at a big picture level, seeing the profound effects that it has on even our lifespan, that helped me then really take a, kind of go from one of the more of a micro level focus to more of a macro level. And really much of my work more recently has now shifted towards how do we take this evidence, how do we implement it across various sectors, including the healthcare sector, and how does this relate to public health so that we can potentially reduce risk.
I give lectures on this topic all the time. It's one of my actual big passions. I had no exposure to this in medical school. I did go to medical school, full disclosure, over 20 years ago. And I think we had really very little on the social determinants of health. We talked about the Krebs cycle and other things ad nauseum. But, I think being out in practice, and I work at a VA as well, I just see every day how, loneliness can affect our patients and ourselves, honestly, as healthcare providers and all of us. And we had the pandemic also enter and show us, firsthand how profoundly important this is. There's some very profoundly, kind of statistics that are come from your work, worse than obesity, worse than smoking a half a pack of cigarettes a day. Perhaps you can just update us on some of those types of things.
When my colleagues and I first published this initial meta-analysis, as I mentioned, the broader public lacked any kind of awareness of this. And so first off, what we found was across these various indicators of high levels of social connection or low levels. So aggregating across these different indicators, what we found was that greater social connection was associated with a 50% increased odds of survival. And so we have this, an odds ratio of 1.5, right? And so, yes, we could have just reported that, but we realized, okay, the broader public is not going to really be able to fully maybe contextualize what that means. And we are so often hearing about the, various things that are good or bad for us. And so I thought, okay, how do we benchmark this relative to things that people do care about and that the medical community takes seriously, right? And so we sought then to take the effect size that we got across the 148 different studies and then look at the most robust meta-analyses on other factors. So we included things like smoking, like alcohol consumption, physical activity, air pollution, obesity. We had several in there. And so we benchmarked this relative to these other factors. And what we found was that this was on par with these other factors. And so I think this was a really important first step in helping to raise awareness of just how important this is, and that this rivals these other factors that we put a lot of attention and resources towards, and that we need to be taking this just as seriously. And I will note that there have been several meta-analyses, several large-scale prospective studies that have been published since my meta-analyses that have replicated this. And so I think that also further underscores our confidence in this finding, because we now have multiple meta-analyses, hundreds of studies, millions of participants. It really, again, just underscores just how important we need to prioritize social connection for health.
And so just looking at your body of work, so 20 years ago, you were studying this actually, way before most people cared. And then you've sort of had this evidence in the cardiovascular universe of outcomes, mortality from cardiovascular events. You've also done work in, I think there's been work in suicide risk, in depression, anxiety, many, many things that affect populations and certainly people living with neurologic disease. And in the recent literature that we have evidence of, the fact that being lonely makes Parkinson's worse, for our patients. And so these are profound problems. We also have increased risk of getting Alzheimer's disease, dementia, Parkinson's. I mean, you name the disease. How can we really bring this home? We have the evidence. What can we do to really change outcomes for our patients?
There's been a few efforts that I've been involved in that I think have some important practical clinical relevance. I served as a member of a consensus committee for the National Academy of Sciences that issued a report with recommendations on the medical implications of isolation and loneliness. And so first off, that report is freely available. But from that work, consistent with these recommendations, my colleague, Carla Persinotto, and I published a piece in the New England Journal of Medicine that introduces a framework for how to address this in clinical settings. It could even be used in other kinds of settings. But we recognized that we need practical kinds of solutions. So one of the barriers that I faced as I was trying to publish some of my meta-analyses was either just not even recognizing the relevance to the readership. I distinctly remember one of my reviewers saying something to the effect of, well, even if we recognize this is important, what can we actually do about it? Right? And this perhaps perception that this may be outside of their realm of expertise or ability to deal with. What we created was a very simple framework that's very flexible. So we call this the EAR framework. And EAR is an acronym for educate, assess, and respond. And so educate is the importance of just as clinicians might educate their patients on various lifestyle factors that either can increase their risk for health outcomes or can exacerbate their existing health conditions. that there's real importance for clinicians to educate patients around the importance and relevance of social connection to their health. Assess is the importance of assessing this in the clinic and recognizing and identifying those across the risk trajectory. And so one of the things that I'm really excited about, actually during the pandemic, I served as a subject matter expert for the Gravity Project, where we were able to establish loneliness, isolation, and social support in the electronic health record. So there are now ICD-10 codes associated with this. There are options for this. I do recognize that different kinds of systems may build it in differently, but it is available in Epic, one of the largest ones, because we often may not necessarily know who is lonely and who is not. And we kind of maybe have this caricature of what we think a lonely person looks like. We often assume this person's an older adult, or maybe, you've got this image of a teenager, in their basement on their phone in the dark. But really, loneliness can look like you and me. We see celebrities, CEOs, even physicians reporting that they are lonely. And so really, we need to assess all of our patients. And in fact, that's a recommendation by the National Academies of Science and Medicine. And so assessing patients, recording that. And then the final step is that R, respond. And that response can be either integrating that into their care through involving perhaps family members in the management of their disease, or finding support groups, or even support among an integrative team that may be able to provide support. Or it might be referrals out through what is often being referred to as social prescribing, and referring to resources in one's clinic. And I do want to note, because I think far too often the thought is, okay, I don't have time to deal with this, so I'm just going to refer out, right? But I actually have another meta-analysis of 106 randomized control trials, all of which were done in medical settings, where patients were randomly assigned to either just standard medical treatment alone, or standard medical treatment plus a psychosocial intervention. And those in the intervention had a 20% increased odds of survival and 29% increased length of survival. There are practical ways that clinicians can address this in the clinic. And it doesn't always mean, although in some cases it really is appropriate, to refer them to outside sources.
Patients are not going to come to you and tell you that they're lonely. They don't even understand that this is something that they should be voicing to us as clinicians, because they don't see it as part of their medical sort of environment. And I think we need to change the sort of concept that this can actually be profoundly important for every health outcome that they may be battling in the clinic. And we as clinicians, I don't even think have realized that this matters for health. So to expect the patient to bring this to us is really, it's not going to happen. And I think it's a highly stigmatized issue as well. I mean, I think people feel lonely, and then they feel alone in being lonely, and like they're kind of like the loser at the lunch table sitting by themselves. And they really don't see that this is such a common issue, right? I mean, I think your own statistics talk about, in aging populations, like over 25% at least, even this was pre-pandemic data, that we're identifying as being lonely. And I don't know what the current, maybe you could just tell us a little bit about the current statistics.
Can vary depending on whether the data includes those that report moderate and severe levels of loneliness, or just severe levels of loneliness. But I'll share just a couple relevant prevalence rates that we often use to draw upon. And so one is the Global State of Connection survey that was done in partnership between Meta and Gallup, that looked at data across 142 countries. And if we look globally, a quarter of the global population reports feeling fairly or very lonely. And so I share that one because what we found is this was truly a global issue. It's not just a U.S. issue. 22 of the highest countries were in Africa. So this really is a global issue. Here in the United States, a study based on the Cigna data, and what they found is that as many as 1 in 2 Americans, so half of Americans, are reporting that they are lonely. And regardless of how it's measured, one thing I should note is that we see this, it's present across all ages, all demographics. No one is immune from this. But that's not to say that we don't see variability. And in fact, what we find is some of the highest rates are among youth, so adolescents and young adults. So again, we have this perception that it's primarily an older adult issue, but actually the highest rates seem to be among younger populations. That's not to say that it isn't also a serious issue among older adults. We find higher rates among those that report living alone, those that report struggling financially. And importantly, and I think this is particularly important to recognize for clinicians, is that those who report either mental or physical health issues and concerns. And so anytime someone is dealing with a health issue, they're at increased risk for becoming isolated and lonely. So not only do we know that being isolated and lonely can lead to and increase poor health outcomes, but poor health outcomes also can increase risk for isolation and loneliness. That's a really important trigger point for clinicians to potentially intervene. The other risk factors that we sometimes see is those that are identified with a marginalized or minoritized community. So this could be based on race, sexual orientation, or identity. Because of that, I think it's also really important for clinicians to perhaps, recognize how this might be playing a role for their patients.
I was reading your work, and the sort of striking thing about us as clinicians being possibly the only touch point for a lonely individual in their lives, and missing that ability to screen and to possibly intervene really hit home for me. So I do ask, quite briefly about this to anyone that I meet. And I think people feel like if you're going to start the conversation, it's going to be a hugely long answer then, and then, we only have 15 minutes or whatever. But I mean, I think once we've identified people, and I really do, take the concept of social prescribing pretty seriously as a neurologist who runs a center of excellence, I'm like, ask, about people, how they're doing, and then go on to ask if they're, feel isolated or left out, or these sorts of questions. And then we'll say, well, this week, I really want you to call your best friend from high school who they may have identified as the person that they is sort of the only person that they would reach out to, and try to make that, part of then the health plan, as I would write, to increase their Parkinson's medicine or to exercise. I now, write that as sort of something that to do, as something as I, as a healthcare provider, has identified as something that could matter for their disease outcome. And I think that makes me feel, sort of empowered, and the patient to then feel empowered to actually do something about this.
I want to just acknowledge that, first off, the medical community, can't solve this alone, but does play an important role. And I think you just, the example you just shared is so important. And I think it also is a good reminder of, that EAR framework, the EAR, although it's, educate, assess, respond, the EAR also is, really signifies listening, right? And so as we respond and provide those kinds of recommendations and referrals and prescriptions, really listening to your patient and understanding their needs and the barriers that they face, because what might be a barrier for one patient might be very different from a different patient. And so those underlying causes and barriers may vary. And so really listening to your patient's circumstances, the context in which this might be occurring. So for some, the recommendation that you have might be critically important. And then for another, it might be another approach because they have a different set of circumstances that have led to their loneliness that could be addressed. And so really, when we think about respond, it's all about being responsive to their needs and the barriers that they face too.
What are some tips that you can give our listeners out there to really implement today in their clinic that could make a difference?
I would first recommend thinking about how you can use that EAR framework and implement that in your own practice. And part of that is becoming educated yourself. A large portion of providers don't recognize how important this is for physical health, but actually see this more as a mental health issue. Recognizing just how important this is can be one of those first steps. But also recognizing how challenging this is for healthcare providers. Time is a real barrier. Identifying ways to integrate this within your practice in a way that can help you really facilitate patient care, right? How can this actually make your job easier, right? So that might be identifying patients' social resources, how they can get the level of support that they need that might help lead them to lead to better adherence to the medications that they might be prescribed or other kinds of practices. But it also, I think, outside the clinic is taking care of your own social health, right? In our efforts to care for others, we also need to care for ourselves. And if we're burnt out and we are struggling ourselves, it's hard to care for others. For some people, that might be setting aside time for your own social, nurturing your own social connections, or in other cases, it might be deepening that, right? And so by strengthening ourselves, we can really help to then help others in our various spheres of influence, whether that is in the role as a clinician or maybe in your role as a parent or as a friend, or we all have multiple social roles that we play, and that there are a variety of ways. And if you're an administrator, the ways in which you can potentially influence policy and practice and operational norms within your organization can be incredibly powerful influences as well.
Yeah, I couldn't agree with you more. I think for me, it's been a buffer for so many of my stress points throughout my life as a mom, a daughter, a wife, a doctor. And I think we forget how impactful social, connections are for each and every one of us every day. And I give these lectures about this because I've been personally transformed through some of your work and others. But there are often clinicians that come up to me and have written to me and said that something I said about this really struck a chord with them, and that they realized how, sort of lonely and isolated they were, and that had made a change. And it, saved them from, perhaps, honestly, one person suicide. So it is something that I think in this day and age is huge. And I think we have been able to normalize it in some ways due to the pandemic. And so I continue to take that opportunity to be able to just ask about this freely, because I think it affected each of us in different ways.
And I want to add, because I think it's important to help clinicians recognize that we have, data to suggest that there are high rates of burnout. And I don't want anyone listening to this walk away thinking, that's just one more thing I have to do that I don't have time for, that I don't have, recognizing that that is a real significant issue. And so I think that it also requires that the larger healthcare systems and medical community take a larger role in supporting this and providing adequate training, resources, and support for healthcare providers, so that it's not just piling on one more responsibility, but rather providing the kinds of resources that are needed to support them in their work.
Absolutely. And I think when we're talking about screening as well, I mean, the questions that we use are, the UCLA 3 questions, takes less than a minute. But even that in a 15-minute encounter can be, eat into the time that you have to be able to spend with the patient. And I think adding on yet another screen or reminder ends up adding to burnout sometimes. And depending on who the person is who's doing the screen, if they really don't then care about the patient and it just becomes part of the paperwork. I myself have had some issues health-wise, and I was asked some questions about suicidality by somebody who was literally also entering my insurance paperwork information in, and that person could honestly have cared less about what I was sort of taken aback by who was asking. So I think the person who has the rapport with the patient, who can then actually do something about it meaningfully and can then incorporate it in the sort of healthcare encounter, should, in my opinion, be the one who is actually screening for this and then making a difference, hopefully, in that health outcome if it exists. So I would love to see this as something that is continues to be talked about, continues to be paid for and in medical encounters, and to be set, sort of given its rightful place as a hugely profoundly impactful determinant of all of our health, and by healthcare and the systems and insurers as well.
One of the things that I think we really need more data on is what are the most effective ways to do these assessments, right? How might that be best approached to initiate that conversation in a non-awkward way that leads to an openness? Because, for instance, just simply asking the questions, have there been any changes in your social life or your connections, could be really powerful, because we know that can be a trigger for loneliness. And so even if they may not be scoring high right now, let's say they just retired, or their kids just left that house, or they just moved and to a whole new area, or they just got a divorce, all of these kinds of major changes could be the start of what could put them at risk. And that's a really important point to intervene before things get serious, because we all know that it's so much easier to get things, to get them early on, so much harder once an issue becomes severe. And that's true for physical health, cognitive health, mental health. The same is true for our social health.
100%. Wow. Well, this has been a beautiful conversation. Thank you so much. I've learned a lot, and hopefully our viewers will take away some pearls as well, and we'll keep the conversation going. Thank you so much, Julianne, for spending time with us today. And thank you for joining us.
My pleasure. Thank you so much for having me.